Hello, everyone. For those of you who don't know me, I am Jennifer Morton, and I spend most of my time in the Department of Nursing, but I also direct a program called the Cross-Cultural Health Initiatives here at UNE. We are so honored today to have Fatuma Hussein from the United Women Somali Foundation here to join us. I met Fatuma about 2 years ago when we started really trying to work on programs here at UNE and with our partners at Portland Public Health, the Portland Housing Authority, the Portland Community Health Center, and beyond to try to secure better access to health care. And what I discovered is that she is probably the biggest champion in Maine. She is one of the founding architects of United Somali Women, and her main office is in Lewiston, but they also have an office at Riverton. And for those of you who have not heard, UNE has been really fortunate to receive a substantial HRSA grant to help provide some collaborative opportunities for academia and health services with immigrant and refugee populations. So Fatuma is a champion for refugee, immigrant, and asylum-seeking populations here in Maine, and we feel very fortunate to have you. Thank you, Fatuma. I think we're starting with a video.
Yeah, the video, yeah. I have to use this because I'm being recorded. Hi, thank you all so much. I am very honored. Thank you for the generous introduction. Maine is really moving in a direction where we're looking at refugee health, immigrant health, what that means, and really do we have a plan in place? We always say Maine is a very white state. I don't think that's true. We're getting a lot of refugees and immigrants, and for those of you who don't know, refugees have lots of children, including me. I have 6 children. This huge population that's really growing, that we need to be equipped to serve all populations, regardless of what their cultural background is. There is a video that I'm going to show. It's about 15 minutes. This video was done back in 2006. It's going to show you the day-to-day struggles of refugees, their vision, their hope in life. It's just, it's a glimpse of how refugees get resettled, what barriers they go through, and I hope you enjoy. And then after that, we'll start the presentation. Thank you.
You have an organization out there who is serving their own population. You know your own people, you know the cultures, you know the issues they come with, you know all of that, and I think she and her organization can service the immigrant population better than we can. We try, we try our best, but you have all the barriers. Serving her own population, I think, is going to be just a great thing.
There are a lot of refugees who are very isolated in their own homes. And they're disabled people, elderly people, people who just don't know how to access services. I always say we have two major problems, which is accessing services and understanding the system. If we knew those as refugees, then we don't need any help. People who come from a war background are always filled with a lot of fear of the unknown. Your entire lifestyle changed. Your family is separated forever. You're changing yourself. Your children are changed forever. So it's a huge adjustment to do it. And then you come here and you've got to learn like a baby. You have to learn everything from A to Z, which is almost impossible. How are you going to do that? As an adult, it's almost impossible to do that. So you're struggling with it every day. So we're always full of fear. Countries like Somalia were filled with a lot of corruption, so it's very hard for us to trust anything. It's hard for us to trust the system. It's hard for us to trust the police. It's hard for us to trust. It's hard for us to trust anybody who comes, through our doors. You have to come here and create a new life. You have to provide for your family. Roles have changed. A lot of refugees are women and children. So you come here and you're the father figure, you're the mother figure. You have to provide everything. You have to drive. You have to learn the English language. You have to work. You have to take your children to school. You have to go to parent-teacher conferences. You've got to go to doctors, grocery shopping, all of this. So you've never done that. And how do you learn it? The resettlement agency will help you for 4 months, and that's the end of it.
Wasiye Denkurani dine masuro Denkurani yorobe kera wasiye Demusoni yorobe kera.
The idea of the outreach is for people to get services. People who are in their own homes, who for whatever reason, whether it's childcare barrier or transportation barrier or language barrier, whatever reason, are not accessing services, whatever the needs are, we go in and connect them to those needs.
Wasiye Melatia Kunusura Wasiya Anyogo Varedile Masuro.
We work with the schools, which the services here don't work with the schools. We advocate on their behalf. So many different things go on with schools every day. If you were to go to a state program or city program or whoever it is, you've got to set up an appointment, you have to do this. There's a formal way of doing things. Whereas for us, we do everything informal, and that's what our people need. That's what we're used to. We're not used to coming here and setting up an appointment. You've got to be there on time. You have to do this, you have to do that. That's not who we are. Our priority is, regardless of how much it takes, whatever effort it takes, we somehow have to help this person. We somehow have to bring the service in.
My goal is I like to help people, so that's why I choose to be a nurse. Gone into people's homes. Most of the families I've been to their homes and in these parent meetings and in the parent conferences. I've really worked closely with her and I've observed her and watched her so that I try to understand more of the cultural nuances, which then enable me to develop better relationships with the parents and the families. Maybe I need to speak with a parent about, say, getting a particular form filled out, but I don't just walk up to the parent with the form and say, will you please sign this? We socialize and we talk and we ask about each other's families and we do all the pleasantries and we take time and then we get to business. I do try to stay connected to not just the child but the whole family. And Fatuma has really helped me to learn how to do that, and through that knowledge I think we've developed some very strong bonds with our families here, and they trust us.
There's big opportunity in America. There's adult education where you can go to learn language. There are skills training, all these workshops and trainings. Americanizing does not mean leaving your culture and tradition behind. It is just flowing. You came to America, you are in America right now. It's impossible to act or to live like exactly the way you lived back home. So when I'm saying Americanizing, what I mean is adopting this culture to survive. You need to go to work. You need to speak English to communicate, because everywhere you go, you need to speak English. You need to adopt the system and do what every woman can do, so that you will have your personality, your tradition, your culture, your religion, and everything. At the same time, you'll be able to step forward and do what every woman can do. And that's why United Somali Women is formed, and that's what they're there for, to make all mothers able to do what they want to do, to reach their goals, to change their lives.
hope you all enjoyed that video. It gives you an insight of what our services are, but also gives you an idea of the daily lives of refugees and immigrants. Most refugees are women and children. Very important to understand that, primarily because when it comes to social justice and equality and all of that stuff, all that good stuff, is not something that we've experienced. And so many of the immigrants who are and refugees who are in Maine are from, African nations, and a lot of the African nations, like American women who have had the women's rights movements and all of that. We have not had that, and so, in the stuff that I'm going to present, just keep in mind that we're really way behind. We're probably about 75 years, 100 years behind. Then, when you consider us, comparing us to United States. And so a lot of the stuff, like why can they do preventive measures? Why can they do this? Why cannot, why can they advocate for themselves? We're women, we have rights. A lot of that stuff is not necessarily realistic to us because we haven't experienced, the changes that the United States or a lot of the civilized nations have gone through. And so many of our voices are not heard. And so we have a few of us who are out there, and our communities look at us as if we're, crazy, or, you're told, are you sure you're a woman? Because you have accomplished a lot. And quote unquote, the accomplishments typically belong to men. So with that, we're looking at cultural considerations in healthcare. Healthcare is very important in a person's life, and also the way healthcare is looked in this country and in many of the developing countries that we come from is very different. And if as a human being, you are really struggling to have food at the table, a lot of the countries that we come from are underdeveloped world. And so if I don't send money to my family every month, I'm the oldest of 13 children. So my parents and my siblings will not be able to survive because a lot of those countries are really, really extremely poor. Even when you're educated, you may not necessarily mean that you're achieving a lot in life. Many people may live under $10 a day, $1 a day, $2 a day. And so in many ways, when you compare that to here, we're very fortunate. Although some of us, I talk to my kids and I'm like, you have to realize I never had 5 pairs of shoes. I never had a bike. I didn't have my own room. And therefore, you have to know what the moral values and the values in life is versus materials, an iPad, an iPod, iPhones, all of this. It's very unrealistic. And so 2 years ago, I took my kids to Africa so that my children can not only walk in my shoes, but they can also realize that there's a life out there. There are children who are starving to death, so that they know, not trying to punish them, but they know what the values of life is all about. It's very important for also us to understand that we talk about women's reproductive health, all of that stuff. It's not a big practice in the cultures that I come from too. And so you ask me questions. I have about an hour, I think. I'll try. My PowerPoint is very long too. You guys can have access to it, but please ask me questions. If I'm going off topic, you can ask me too. I don't get offended either, so ask me any question. So the picture has Somali Women. It's a World Health Organization in terms of health. It's a complete physical, mental, spiritual, and when you talk about health, in the refugee context of health, when you as a health worker, for instance, go into someone's home, housing, social security benefits, school issues, my transportation, childcare, everything comes up. And so this whole idea of, we're the health field and we're, the mental health and we're this, all of that stuff, that concept is not necessarily, we don't understand that concept because we're not, again, where you are in terms of the progression of this country and what this country has done in terms of, delivering health. And so as a service provider, all of those pieces are going to come to you when you're dealing with refugee and immigrant because we feel health is everything. It's just not my physical body health, but it's my mental, it's my, food, it's my housing, it's everything that encompasses me to be a normal person, to be able to feel safety and to be able to feel health. There is a definition here, and I'm going to go through these PowerPoint slides very fast because I don't have much time. I like people to ask me questions, so if I'm moving fast, just know that I'm trying to go very fast because there's a lot around barriers that I really want to focus on. Again, health is a personal and social state of balance and well-being in which people feel strong, active, wise, and worthwhile. In 2006, we did a survey in the Lewiston area in conjunction with Bates students. And that research, what we're looking at was what are the top health issues refugees face when they come to the United States. The three top health issues that refugees experience upon arriving in the United States were all mental health related issues. Now, we as refugees did not necessarily define that as mental health, but they were all the symptoms of mental health. People said, they cry for the first 6 months, they want to go back, they feel isolated, there's so much trauma that we don't acknowledge. My childcare, my babysitter said when she had 4 sons, and her husband got killed in front of her children, and her 2-year-old, she was holding the 2-year-old. And so that woman complains about body aches and headaches and all of this, yet she doesn't acknowledge mental illness. And so, there's so much trauma that we all carry. There's so much trauma that, especially if you're coming from a war background, there's so much that you have experienced. And as women, we have many raped victims. And so our conclusion based on this research was, the Somali culture, I'm Somali, the Somali culture, everybody feels like they're normal. It's like we have never had any trauma. We have not had any issues. We had to pick up the pieces that we had left, and we had to move on in life as if life is normal. And so now we are sensing that, no, we are not complete. Something is missing. And so you're seeing many people who are seeking for mental health, culturally and linguistically appropriate mental health services, which is a big leap for us. It's a stigma. There are very few patients that we're seeing are getting counseling services. And so that is a big, in my opinion, a big accomplishment because, how can a whole nation go to war and everybody's perfectly normal? It just doesn't work. So what's culture? I think culture is the way we do things around. Culture is you. There is I came to this country when I was 14, maybe 15. And I don't want to talk about my age, because in America, we don't talk about age. In my culture, you have to say, what's your age? And you have to literally state when you were born, the date, the month, and the year. And so now, being Americanized, I really don't have to talk about my age. But when I came to this country, I was 14 years old. So I went to high school here, which, by the way, was the hardest experience that I've ever had. It's hard to be a teenager, to not have family support, to have, to look different because I'm Muslim, so I'm wearing my native clothes. to be a woman of color, to be in a very white. We were settled in Norcross, Georgia, which is extremely white, suburban Georgia. Yeah, I came from Georgia. And 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 we were like, I was like, something is wrong with this, because you have to transition from your eyes seeing people of color to your eyes seeing nobody, close to nobody, and it was hard. The kids, I always say, high school is the most hardest place you can ever be. It's so crucial, and so my daughter's in high school right now, and I totally feel them. I totally can relate to them. Although I will let my daughters wear jeans, and if it's a prom night, they'll go to prom, and I'll have to hide it from my native Somali women because they're going to scold me and tell me, "Are you trying to Americanize the girls?" And I'll say, "No, but they have to." So I make excuses all the time because we're looked at as if we're very assimilated, and my folks may get offended by that. It's not because they don't want to adopt skills in the American culture to enable them to survive. It's because there's a lot of fear that you're going to lose your culture and you're going to lose your roots. And I'm very proud of who I am, And I tell my daughters that, but they don't get it because they think, my daughters think they're American and therefore they don't have to be Somali. So there's always, the back and forth conversation around culture and being multicultural family. Culture is what you are. It's who makes you. It's you. So a lot of times, although I am aware of my environment and my surrounding, and I'm trying to flip-flop between the two cultures, the American culture and the Somali culture, my Somaliness will overtake almost the American culture in an instant because I'm Somali. So regardless of how many years I'm in this country, literally got raised in this country, I'm still Somali. And so because of that, the cultural lenses that I'm looking at through things, through life, and coming into a medical setting, and I'm telling you that when you tell me, you had a baby 15 months earlier, and now you're 2 months pregnant, there are options out there. I'm looking at you as if, come on, my culture tells me it's okay to have children all the time. And so is my religion. So what are you trying to tell me? And so we're in two different, we're looking at two different things. And so culture is so important for you to, as a service provider, to pause and say, okay, I know that I cannot walk in your shoes, but is there a middle ground that we can both work from? Because if you're not trying to relate to that person, then your service delivery may be tweaked, and the outcome may be really bad. And sometimes it's dire, because we have people who, we had this incident in Lewiston where it was a young man, and he needed some surgery, and because of the translation and the cultural differences, the outcome was really bad. Really bad. And so we had to go back and try to see what happened. Even interpreters, we all make mistakes. And so it's important to really look at, when you're working, looking at, the basis and looking at the culture and then moving forward from there. Again, cultural beliefs include all of this: family structure, expectations, and beliefs around illness and wellness is very important. We, as people who come from Africa, especially people who are Muslims, African, different cultures, we rely on spiritual healing a lot. So our first option is spiritual healing. So when I get sick and I feel like I'm depressed, I'll be like, oh, I really need to go get some Quran, which is the book equivalent to Bible. I will be like, I need to go talk to a sheikh, which is an equivalency of a priest. I need to talk to him, and they need to recite some Quranic verses on my body before I can make my doctor's appointment. So that's my first instinct. If my daughter goes, out of control, I'll be like, oh, she needs some Quran first to calm her down. We're talking about two different perspectives. And how do you bring those two different perspectives together? Because they can work together. Now, if you look at the American, or Western way of doing things, in medical settings, you see priests who are, saying prayers, there are Bibles in the rooms, there's spirituality there. And so we as refugees often feel like, if I bring my spiritual beliefs into this system, maybe I'm getting in trouble. There's a lot of fear. Again, we don't know what this culture is. We are very scared. We are scared of the white person because the white person represents government and authority to us. And so when I see, and I'm using the white person not in a bad way, but excuse my language. And so I just don't know how to, what else to use. But I'm trying to differentiate the two, and we come from countries where we were colonized, and then the next leadership or our African leaders have oppressed us a lot. Corruption, bribery, no development. People are paid. There's so much that goes on, and so almost a human right is, we don't know what that is. We can't relate to that because we were not exposed to that. And then you're coming from one extreme end to the other extreme end. And there isn't really any in between because, when I came on that refugee plane, that plane that brought me from Mombasa, the refugee camp, to here, I'm sorry, but I really didn't build, those bridges or those baby steps to realize that when I come here, I am going to need so many tools in order for me to be successful in this country. When you are in a refugee camp, you're shown a video, and that video shows you a perfect American family, a nuclear family, with, a house, a car, and so you're coming into America thinking you're going to be instantly rich, and all your problems around money and inequality and safety and everything is going to be left behind. The reality is very different. You're uprooted from very extended families that really, when someone says, I'm going to have my child babysat by my sister and I have to pay her, we wonder, are you out of your mind? Why would you pay your sister? Isn't the expectation for your sister to help you out? Are we not supposed to help out each other? And so we come from that communal living. The whole village raises that child. If that child is out of control, you get spanked. There's nothing wrong with all of that. You're coming from that norm to a very different aspect of life. And so when we come here, it's very lonely. There's a lot of fear. We're very scared. All of our cultural beliefs now, we have to second guess them because we really don't know, if I go this way, am I going to lose my immigration status? Does that mean deportation? Am I ever going to be able to rejoin my family? Can I bring them here? Is there reunification aspects for me? What does the future hold for me? Everybody is very individualized. And so you wonder, why are these people just rushing all the time? Why are they driving all the time? Where are they running to? We're told, come here at 10 o'clock sharp. Well, if I'm late 15 minutes, what's the point? I mean, it's okay. All of those pieces. And so all of those pieces encompasses your whole life, and it makes us retract slowly. We don't see it, but we retract slowly. Instead of me going out there, and instead of me trying to fight so hard, it's important for me to just stay within my comfort zone. And so my comfort zone is to be able to stay where I am, to be able to relate to the families and my neighbors, because now I've lost all my family. I'm just here. I don't have a lot of extended families. And so everybody's in the same boat. And so all of the cultural beliefs that include all of these pieces, sometimes I get tweaked, sometimes I get diluted because We're just so scared. We're just so scared. Now, if you talk to me, I'm like, I can practice my cultural values, and nobody has a right to tell me what to do. Rather, I will educate the other person about my cultural values, and then we can all get a middle ground so we can all work together. Those are pictures, and these pictures say a lot. You've got two children. This is a refugee camp. When I'm talking about a kitchen in a refugee camp or where I came from, I'm not talking about a stove, and I'm not talking about a blender, and I'm not talking. Now, don't get me wrong. A lot of refugees who can afford to do that had that. In Somalia, there were rich people, but majority of us came from rural areas. Majority of us didn't have money. Majority of us were not in a power. Majority of us were not coming from families that, were running the government. And so the normal Somali person, the average Somali person, has had very little or nothing. And so when I'm talking about a kitchen, I'm not talking about a kitchen that has stove and blenders and all of that. I'm talking about a kitchen that has 3 stones, a big pot, 20 people waiting for food, and I don't know how I'm going to get that food for everybody today. And so it's a whole different perspective. Why is self-awareness important? I think it's important for you to identify your own cultural and family values. It's important for you to become aware of your personal biases. I strongly believe that we all have biases in us. Sometimes I go into grocery stores and I have opinions. We all have opinions. We're entitled to our opinions. But it's important for you to separate your opinion from service delivery. When you're a service provider, it's important for you to acknowledge where you are. And it's important for you to understand that, what you believe influences also your service delivery. And so how do you separate the two? It's important for you to understand that the cultural lens you're looking at me from and what I'm looking at are 2 different lenses. 2 different lenses. And so somehow we have to use a medium. And, our agency is very, very big at cultural broker services. Cultural broker services are people who are able to walk in both shoes. They are able to walk in both shoes because they have lived in this country and understand the system in this country and system deliveries, are able to navigate that system, and that person is also able to educate you as a service provider. They become the liaisons, they're the link, they're the bridge between you and that person. They're more than interpreters. Interpreters only interpret and convey the language back and forth. Cultural brokers are advocates, educators, liaisons, you name them. They're everything and anything. Cultural broker concept is fairly new in Maine and doesn't necessarily have formal training. We did a cultural broker program for Central Maine Medical Center in 2006 through 2009. We had one patient say, the best thing that United Somali Women ever did was that, because it made a big difference. We had a woman who had her daughter as an interpreter for 3 years. And the daughter was a teenager, and you know how teenagers are, you're embarrassing mommy. My daughter, when she was in 6th grade, she'll tell me, you're the best mother, mommy, you're the coolest mother, because I was the youngest mother, right? Now I'm telling her, Sophia, what do you think about me? Oh, you're embarrassing, don't come near me, because now she is in 9th grade. And I try, mommy, are you coming with me? Then make sure, mommy. I like the Somali piece, but just tweak it a little bit so that it can look cool. I'm like, forget that. So this girl who was in high school felt so embarrassed about her mother, who might be having some mental illness and issues, to convey the message. And so she will tell her mom, no, why would you complain about your back? Why would you complain about your head? The doctor And so one day, this mother came to our office and she said, I really need help. I have a doctor's appointment and I need someone to drop. And literally, we respond to crisis all the time. So we literally drop everything and go with that person who needs the need right now. So I took her, and when we went into the appointment, the doctor kept looking at me as if I was just saying things out of the blues, because he was hearing this for the first time. And so I had to explain to him that I think, you had a teenager. First of all, you're not supposed to use family members as interpreters, because they can keep a lot of information from you as a service provider. There's Title VI. Interpreters, we are entitled to interpreters. And so if you can't afford, then if the patient is a Maine Care person recipient, then Maine Care reimburses interpreter services. If you can't, there are resources that you can use within the community that can help you accommodate that person so that that person's needs are met. And so I had to educate the doctor. We had to go into a whole, reviewing what has happened in the last 3 years. We had to come up with a plan. We had to help this mother. That mother is healthy today. And I had to go back and give the teenager a speech too, because she had no right to do that, And she told me, well, I was embarrassed, and my mother is complaining about so many different issues that she's just embarrassing me. And so I said, that weight is lifted from you. You don't have to interpret for your mom anymore. But please, if she needs anything, let us know. Don't, because some of these things are life-saving, issues, and it's important for all of us to be on the same page. So approaching service delivery, I'm going to go through so fast, and I'm checking my time. I only have 10 minutes because I want to leave half an hour for questions. One's own cultural lens is very important. There's significant cultural differences that might relate to healthcare. Like I said, we have, and one of the things that I think it's important for healthcare service providers to also realize or understand is, when a refugee immigrant person is seeking for healthcare, they become sick, they call the interpreters because, prevention is not necessarily realistic to us, right? So I'm not going to say, I need my 6-month dental cleaning unless I have a toothache. Now, if I have a toothache, I'm going to run to the emergency room. And so there's a lot around that. And so, a lot of refugees are going to seek for care when they're sick. They're going to, and we need to change that. I'm not saying that's right, but that's what we have for now. What's happening is once they call the interpreter, they don't call the doctor themselves or the doctor's office, the interpreter will set up an appointment for them. So they are going to get transported to a doctor's appointment. They're going to meet with their doctor. They're going to be diagnosed, and they're going to get prescription. The interpreter may be helpful in the sense that they may also help them obtain the prescription and transport them back, but not all interpreters do that. Once they're at home, then what? I don't speak the English language, neither do I know the instructions that's on the bottle. So who is safeguarding that I'm taking the medicines right, that I am, doing what I'm supposed to do, that I am not fasting for 30 days when, in fact, I'm a diabetic patient? So there's a lot that has to happen at home to be able to have this person become healthy. And so the problem doesn't go away. Then I come back because, my sickness is still there. I'm getting worse. I'll come back. And then I'm going to get some medication. I'm going to go back home. I'm going to the same routine. I'm coming back. And so doctors are saying, okay, what's the problem? Why do you keep coming back for the same issue or for another issue for that matter? But what is it that we need to do better? And so it is very important for service delivery, service providers, healthcare providers, to sort of maybe talk to the interpreter. If you don't, for instance, we know that we have limited resources, and we know that nobody can, police people who are sick at home. But if there's a way you can talk to the interpreter to make sure that the interpreter, or better yet, the cultural broker, that to make sure that this patient is taking their medication, they're following the directions, or the people who can check in on them frequently, because we have community workers, we have cultural brokers, we have outreach workers like our agencies that are in the community. There are community resources out there that can be utilized to ensure these people get better. And they're not, and it's a drain on the system too. It is a drain on the system. If we're going to the emergency rooms all the time, if we're doing this, if we're doing that, and we're not doing preventive measures, it's important for all of us to be on the same page. There is a distinct views of health, illness, end-of-life experiences, and appropriate care. Now, when we have people who are ailing, and again, I'm going to give an example of Somali person who's really ailing, who's dying. You should see that scenario. It's not a funny scenario, but the gap between the interpretation, the service provider looking at things this way, and we, the whole community, I mean we, not that only person, but the extended family, the people from the mosque, the friends, we're coming by dozens. We're coming by large numbers, and we're not following directions. And we're not, and the nurses and the service providers are looking at us as if, is it the whole village? Is it the whole community? Who invited you all? Do you have permission? Do you, and some people who are really in protected areas, they ask for, do you have permission? Are you supposed to be here? Well, it's irrelevant to us. We just march in and we go in and so it's huge. The way we look at illness, the way we look at health, the way we interpret health, and the way the Western, healthcare providers interpreting are two different ways. And so my thinking is, I know this person has an IV, and I know this person is on bed, but we Muslims, when we go to a bathroom, we wash, and we wash for prayers. And this person has to pray 5 times, even when they're dying. And so there has to be some education. There has to be a link. There has to be a way the service provider and the communities and the patient work together so that we can have the best delivery possible for this patient. And again, I'm going through all of this. Western medicine's approach to illness and care is scientifically based and grounded primarily in the physical body. Ideas of interdependence versus community. My community is a big part of my life. And so if I'm having a doctor's appointment, I may have my aunt, I may have my uncle, and we're all coming, the interpreter. And you, as a service provider, is saying, okay, wait a minute, am I supposed to share this information? Who invited them? Why are they here? You're supposed to, you're the only one who has, and sometimes you're talking about really chronic issues that are very confidential. And so you may ask the other community members to go sit in the lobby while you're talking to a patient. Oh my goodness, speaking of being furious, they are so upset. They don't think you have a right to tell them to go wait out there. The healthcare system here is the patient-doctor relationship or patient-service provider relationship. We're looking at, the service provider and the entire community relationship. And so how do you balance the two? So there has to be, again, and I'm emphasizing on education, there has to be education going on there. Because confidentiality also in the communities that we live in is very irrelevant. You're talking to me and diagnosing me with cancer, and before we get out of that room, everybody in my community knows. Speaking of viral, that YouTube stuff, then it's like we're way, way better than YouTube. I'm telling you, our stuff goes so viral. It's not a joke. And so it's very important to try to safeguard the patient's information, to be able to directly work with the patient. But again, if you have someone, not necessarily an interpreter, and I'm not bashing interpreters, I really respect interpreters. But I think the cultural worker can do much more, because the cultural worker is educating you too, and making the patient understand the system and what their options are. Because sometimes you're telling us, okay, here are the options, and this is what we're supposed to do, and what are you going to do? We're not people who go into surgery just like that. You're going to have to persuade us so much. You're going to have to, because I believe if you're telling me I have, let's say, a cyst, and you have to, remove it, otherwise it may have some implications in my health, I'm telling you, look, what you're telling me is okay, but I believe my spiritual healing is more powerful than what you're telling me. So I may not agree with you at all. And if I do, sometimes the issue is, too late. And so there is a way that there has to be a way where you are able to convey that message in a way that it's not threatening to the person, in a way that this person understands. Because there are a lot of us who need surgery and really huge medical procedures who said, no, we walked away. And those people are really sick. And they complain, and you see them through our work. We see them, and I'll be like, okay, you're complaining about your nerve in your head. What did your doctor say? Well, they said surgery. And those people, they just rush to surgery all the time. They tell us to go to surgery all the time. Why would they have to cut my head open? Because my fate has been pre-told. When you talk about pre-planning, let's plan for the summer. I'll be like, are you kidding me? I'm not even sure if I'm gonna get to summer. Let's get to the summer first, and then I will tell you. So this whole planning, this whole idea around 10 years of planning. Urban schools planned 10 years prior to building Park Avenue. And so when they built Park Avenue, where my kids attend, they took the ELL program from Sherwood Heights and they brought it to Park Avenue. Trying to convince refugee parents to go from Sherwood Heights to Park Avenue was a mountain to climb, because it was hard for them to understand. Why would they pre-plan 10 years? What was the plan about? We spent the whole summer, literally, to really explain to them. And so it's very important. Again, I know that we all come from different cultures, and we all have different experiences. But I also think if we're saying we're going to provide services, then the service provider has, there's an expectation that lies within the service provider to be able to do whatever it takes to provide that care for that person. Acculturation is what we talk about all the time. We like to use the word acculturation versus assimilation. I think acculturation is a process of adapting to a new life without really giving up your life and your roots and your culture. And it is a very scary process for many refugees. A lot of refugees, especially for young children, most parents feel like these young children are going to lose their roots. They're going to lose their culture. They're going to lose something. Well, that's a reality. It is, if you go to Somalia, you're going to lose some of your American ways of living. It's the reality. However, I strongly believe, and I tell my fellow Africans, that there's so much that America can offer us. There's so much that we've achieved from the American life, and the opportunity, the idea of getting a second chance, the idea of really getting here and being equal. I can just go out there and say, you know what, I have a right. I couldn't say that in my country. And so the acculturation process, we often talk to them about adapting skills, making sure that you adapt skills. Like I'm driving, I wouldn't be driving in my country. Most of us are not educated. Most of our men are educated for a reason, but most of our women are not educated. My dad, we are 7 girls and 6 boys. My mom had 3 girls in a row. And my mom, my family is rallying around my dad. You need to get married to another woman so she can give you a boy, as if you insert boys or girls in you. You have no choice. So from that perspective, my dad, I remember when they say, oh, it's a girl, nobody's coming near my mom. When it's a boy, oh my goodness, they'll slaughter all kinds of animals to celebrate. Who saved Somalia when Somalia went into war? It was the women. What were the men doing? They were partying. And I'm not kidding. Even if I had Somali men in the audience, I'll say the same thing. It's true. The Somali woman's role has changed today because we women came into America and other countries. We were able to provide for our families. And so today in the Somali culture, when you hear a boy, there's always like, something, we're losing something. So there is so much that has changed for us. And therefore, the process of acculturation, coming to this country, having a second chance in life, having opportunities that you will never had otherwise, your children being on their way for a bright future, all of that, we're very grateful to that. Any questions so far? Oh, I am running out of time too. Yes.
I have a question. When you talk about healthcare service delivery and the family or extended family coming with, and how to decide how to keep certain information private. So if someone's there for a domestic violence type injury or situation, like how would you recommend that the cultural broker help the healthcare provider navigate that without causing a worse safety issue?
Right. And cultural brokers are trained and they specialize in that particular field. I think it's important for cultural brokers to, for instance, get trained around domestic violence. It's important for cultural brokers to get trained around sexual violence. It's important for cultural brokers to get trained about mental health. Because they specialize in that background, or we get trained in all of this, and at least you have a glimpse of what that looks like, they're able to buy into the whole notion of domestic violence. A lot of the cultures that we're talking about don't talk about domestic violence. They don't acknowledge domestic violence. They don't think it exists. And so there's so much that the cultural broker has to, because the cultural broker came from this culture too. And so the cultural broker has to be trained in that background. And that's why we 2 years ago, we trained a lot of interpreters around domestic violence and sexual abuse, because what we were seeing in the courtroom was, part of what we do is domestic violence and sexual assault. And what we were seeing in the courtroom was when the victim was talking to the judge and the interpreter was interpreting, the interpreter was not necessarily interpreting, he was scolding the victim. He was telling the victim that you're shaming my community, you're doing this, you're doing that. And that's not right, because when I see a woman who has been burned on her back is burned with the stove and that stove thing is on there, come on, give me a break. That is domestic violence. And so what the cultural broker needs, the service provider needs to convey to the cultural broker is for the cultural broker to understand and to educate the extended family members that maybe there's a procedure, or he needs to look at her, or he needs to do something. Could you give us a break? You're going to have to make up some things, a white lie, right? You're going to have to do something to be able to get them out of the room, because there is no way that victim is going to talk to you about the issues that are going at home. So because if the extended family or the family members who are in there are aware of what's going on and hear all of this, there's a high chance of not having the victim receive services. So trying to, and that's what the cultural workers are good at, is to try to sift through all of that and to try to put these people so that this victim can feel safe, can talk. And even then, the victim may not be able to talk because she comes from that culture too. She wasn't empowered to see that as a wrong act. I'm gonna flip through this. I'm so sorry. So this is what I want to focus on is how immigrant refugees, the differences between those three categories, and how do they receive healthcare services in our state. So immigrants are foreign-born individuals who has been admitted to reside permanently in the United States. So they may come by choice, by not choice, but we don't see a lot of that in Maine. We don't see a lot of immigrants in Maine. What you see is refugees and asylum seekers. Refugees are people like me, a person who has sought for refuge for many reasons. And so any person who is unable to return to his or her own country because of a well-founded fear of persecution due to ethnic, political, religious, or other affiliations is a refugee. So refugees have their refugee status. So we're not illegal immigrants, because you see a lot on TV around immigrants. So we're not immigrants, we are refugees. We come in because the American government has recognized us as refugees, and they give us our refugee status. So we go from Somalia, we flee Somalia, go to Ethiopia, Kenya, whatever, get our refugee, go into a refugee camp, and in the refugee camp, it may take you 10 years. It may take 15 years. We've got people who have been there for 20 years, are still waiting for their resettlement. So it's not something that you zip through. We were in the refugee camp for 2 years. And boy, it was extremely hard, because there is like Lewiston, when Somalis moved to Lewiston, the Lewiston mayor wrote a letter. Lewistonians were saying, okay, we don't want you guys here because we feel like you're taking over our city. It's the same idea. So when we went to Kenya, the Kenyans felt like, we don't want you here because you're coming to max out our resources, and therefore we don't want you here. So they will burn down the refugee camp. They will, vandalize things. So my family, we were 18. When the war took place, I was visiting my cousins, and so we didn't know, do we know we're going to Iraq for war? Nobody knows, right? The government officials decide this, and you hear on the news. And so we didn't know Somalia was going to war. Well, we heard all of this, and we're children. How do we know anyway? And so when I went to visit my relatives, my family went to Ethiopia, we went to Kenya. And so I didn't see my family until 2007. So as a young child, I am, mixed with this 18 family unit. Most of us are men, but those men, I remember, they will watch us overnight, every night, because we were susceptible to being raped or being hurt at any time. There was so much fear. So coming from a war to that, and then here. So when we come here, we have our refugee status, meaning we are legal refugee or immigrants. When we come here, we get our refugee status for 1 year. It's called I-94 card. And then the I-94 card, assuming that you're in your best behavior and you don't run into issues with the government, you get your permanent residency card after 1 year. And then after 5 years, you apply for your citizenship. And so you and I are the same. The only thing I cannot do is being a president. But if I'm a citizen, I can do anything. So what happens is refugees receive a lot of good health care. When they arrive in Maine, because they're primary refugees, what happens is the resettlement agency will connect them through DHHS public health nursing. And so they get a complete physical and get all of what they need, tuberculosis, TB testing, medication, everything. And refugees bring their medical records with them. So those are called primary refugees. What you see in Lewiston is what's called secondary refugees. Those secondary refugees, again, two different subgroups. There are refugees who are called secondary refugees but have arrived in the United States maybe a month before they came to Lewiston. Those are still considered primary refugees. So those people don't go through the cracks of the healthcare system. They are really well watched. They are really coming into a very well organized healthcare system, and they're connected to their primary care physicians. They're connected to the healthcare needs that they need, the complete family. And so we know who they are, and they work with the public health nurses and all of that. The two groups that we really don't capture a lot is immigrants and asylum seekers, especially asylum seekers. Asylum seekers are individuals who have sought protection for fear of persecution. Protection is generally sought upon arrival in a third country. So what they do is they have their Kenyan passport, probably a fake passport. I come on the plane, and I'm coming to Boston. Once I come to Boston, my passport disappeared in the midair somewhere. So when I come, I have nothing. And so I give up my rights. And so immigration in the United States will take me into custody. Or I may not be able to get into all of this. I may come through Boston, come to Maine, and then say I'm going to apply for asylum. So they come through the country in various ways, but they're asylum seekers. And so they go through a very long process of trying to apply for asylum and being granted status in the United States. And so those people, because they don't have status, a lot of us cannot work with them. Like the resettlement agency cannot work with them. They may seek for services through the city's general assistance, emergency assistance. But their healthcare piece is really in limbo. And so it may take them 6 months, a year, 2 months, a day. It's them who are trying to get into the healthcare system because they don't have main care either. They don't have no way of paying. And so if you're not sick, you're not going to go because you don't know who's going to pay for it. They may not be educated about free care. They don't know a lot of this. And so asylum seekers, Maine has seen a huge jump in asylum seekers in the last 2 years. It is a large population. They're primarily from Rwanda, Congo, Burundi, and Djibouti. They have jumped huge numbers. They're almost over-numbering the primary refugees that we see. And so those are the populations that we have to be very keen on and very aware of because they have significant health needs, yet we're not able. I know the state of Maine just put in an RFP around asylum seekers to really look at where the health piece is and how can we try to get asylum seekers into the healthcare system so that their health needs are met. I am running out of time. I'm so sorry. Any questions? I'm going to go into the barriers very quickly, but do we have, okay, there's a question there.
Yeah, just to follow up on the last question about confidentiality and interpreters. I mean, you mentioned that when you walk out of the healthcare system with a diagnosis, it's viral within minutes and everybody knows, but you also mentioned that these interpreters are coming from the same community. How, as professionals within the industry, do we evaluate the interpreters? I mean, and evaluate them in terms of how effective our care is to you as the patient?
I think Maine doesn't have a certification process for verbal or speaking interpreter language, spoken interpreter language. So there isn't really a lot of mechanism or rules in place. LANA, the Language Access for New Americans, was created, I think, almost 6 years ago, did a lot of work around interpreter training, really had mechanism around even a complaint system, like the incident that I'm talking about in the domestic violence field. We complained about that person, and that person could no longer interpret in the court system, which was a very hard thing for me to do because, they can pinpoint who did that. But we're there to serve the victims, the clients, the people that we serve. And so there isn't really a mechanism to do that. And so what we do is, a lot of times, if we're working with people who need, first of all, let me back up. There are trainings for interpreters. So they do the 12-hour basic interpreter trainings. They do a background check. There's a language proficiency test that they do. So there's some standards that were set that many of the companies, the healthcare, agencies bought into. It was all of us coming together and saying we need to set up some standards for these interpreters because we were getting a lot of complaints about incidents. And so these standards have somewhat helped the interpreters to be at a different level. Our complaints have gone a little down, but the client will never know what type of service they received or what type of interpreter service this interpreter did for them because there isn't a way to understand. They're not able to relate to both languages. So I think it's the service provider who, and I keep emphasizing on the service provider because the service provider is in the driver's seat. So the service provider has to make sure that if, for instance, I'm just talking, or the interpreter talks to you, at a length, and the client isn't saying much, you know that situation somebody is invading and somebody's telling you, So there are ways I think the service provider can detect that there's an issue. The other thing is, maybe trying to use other interpreters. Let's say you use me today, using another interpreter, and then making sure that you go back and ask the other interpreter, the new interpreter, well, 2 weeks ago we had this appointment. I said this and this and this. Was the client able to understand that? I think it gives you a glimpse into whether or not your messages were conveyed to the client. But there are ways, if it's a bad interpreter, you will know it's a bad interpreter. I can't sort of pinpoint, but you will know. And the other thing is, if the information goes back into the community, the client may come back and complain about that. And there's some clients who say, look, I don't want that interpreter anymore. This language line also. Language line is another option. In the domestic violence work or sexual abuse, assault incident, I think using a language line is perfect because sometimes you have no idea as a service provider if the interpreter is my sister-in-law. You don't know. This whole idea around conflict of interest may not necessarily sit well with us. We may not tell you that the client that you're seeing, the patient that you're seeing is my sister-in-law. And there's abuse happening in the home. And I'm going to protect my brother. I am so sorry, I'm running out of time. Refugees' needs and the healthcare system. Obviously, it's a very complex history. I think moving through cultures, diverse medical, psychological belief, and all of those pieces. There is, the idea around if a refugee is sick or we think she has a mental health illness, there's a low status within the refugee culture. For instance, if even not healthcare, if let's say my daughter did a bad choice, for instance, or my daughter got pregnant out of wedlock, it reflects my style of parenting. It's my fault. So there's so much that all of this is woven into, and if a refugee family has a 15-year-old girl who got raped, who seeked for some healthcare needs, that family, the stigma, we're not going to go near them. We're not going to get married to their girls. So there's a lot that's associated with health that you as a service provider has to be aware of. The cultural broker can educate you a lot more than you think. If you have questions, ask the cultural broker. That's the numbers of refugees. 75% are women and children, 65% are African, 67 Muslim, 10% elderly. So it gives you an idea of who we're dealing with as refugees. And I'm going to go through very quickly. I don't have much time. Most vulnerable population, children and youth, women, elderly. My culture does not look, and I'm saying this because some people are going to get upset at me, but the elderly are people that we don't address. And it's not fair. It's not right. So we have a lot of elders, very isolated in their homes, who, speaking of trying to acculturate, it's extremely hard for them. And so, and then we have survivors of torture. We have people who have just gone through a lot. That's a nice picture. I really like that picture. It just reminds me of home. Again, pre-immigration, this is what a refugee camp looks like. This is pre-migration, during migration, and post-migration. So I am at post-migration, speaking of 19 years, but you just don't leave this behind. You don't forget this, the refugee camp, the pictures, the violence. It's often, it stays with you. And I think it's very courageous for a person to lose everything, to pick up pieces, and to move on as if life is normal. It's extremely courageous to be that person. Barriers to access healthcare, language, very important. We need to have language access. Language access that, I don't care what it is, not using family members, not using husbands. We have domestic cases where husbands were the interpreters. Hello, give me a break. He was the abuser. He just did all of this. How can you use him as an interpreter? And then guess what? She gets arrested. And then we hear about it. And then we go after the system and we get her out and get the whole case dismissed. But speaking of trauma, it's hard. It is hard. Interpreters, we need bilingual interpreters. We need interpreters. So we have people who are, qualifications bilingual versus interpreters. Interpreters are trained professionals. Maine doesn't have a system to address spoken language interpreter service. In other words, certification process, a process where you know that you have a certificate. There's a board looking over you. If there's a process where you can file complaints. We don't have that. We have that for deaf services, but we don't have that for spoken language. So it's hard. So I can be out there and come to you and say, I am an interpreter. So you, as a service provider, have to look at the standards I just mentioned. There's a proficiency test, there's the language, basic interpreter training, which has all the rules around interpreters. There's a background check. What if you have a sexual assault, person who have done that to children, who's not supposed to be near children? So if this facility, if UNE is using interpreters, those standards have to be on the record. A lot of our interpreters do 100 hours of medical interpreter training. It's huge. You need to have that. The more training we have, the more interpreters are qualified, the more they're out there, the better they become, and that's how the patient receives better services. Cultural issues, gender issues. I am so sorry, it's 1 minute. Gender issues, it's huge. We come from a very male-dominated culture, and I say that, not offending my African man. I'm very proud of my cultural background, but that's where we come from. And so often women, that overriding stuff. And then I talk to my daughters, and they feel like they're very empowered. I'm like, we're coming from two different perspectives. Childcare is a huge issue. If you have a lot of children, you may not be able to even have time to go to a doctor's. Money, asylum seekers are people who really I feel for. Because of lack of money, because they cannot afford, they don't access healthcare. If they're accessing healthcare, a lot of them are going to emergency rooms, which is not. We need preventative measures in place. Healthcare options. What options do we have? Do we even know we have options? Where do we go? Transportation is a huge barrier too. Bias, it is there. It is there. The healthcare service provider, a lot of times when you walk somewhere and I'm wearing these clothes, this assumption that, do you speak English? And I'm really nice. I'm nice. I want to educate. I want to educate the person. I want to educate that person. But you go into Hannaford's and you're lining up, and the cashier says, "Okay, can you swipe your food stamp card?" Assumption, right? And so, depending on my mood, I may I may go off on that cashier. No, I'm just kidding. But we have to let them know that we have people who work and pay into the tax system too. My husband and I pay a lot of taxes. Do I want? No. Language is a big thing that I really emphasize on, and you can have Title VI. We have a right. If you don't speak English, the United States government gives you the right to have language access. So there's some legalities there too. And there, maybe one question. I'm so sorry. I actually did good, I thought.
Like this. Oh. You were talking about how Somalia is this male-dominated society. I'm curious as to how you are received as a well-spoken, knowledgeable, empowered woman.
I have a hard time, for sure. I'm just kidding. Yeah, it is hard. It is hard. I have people who complain to my husband as if my husband is going to tell me what to do. I know. No, there are boundaries, right? He's the male figure, I'm the woman figure, and we both combined, we make a family. So, I'm like, you walk in your lane and I'll walk in my lane, and we never, I'm just kidding. But it's really hard. It is hard. And when I'm working with men, because although our agency works with women and children, but we look at the whole family unit. And a lot of men will tell me, "Oh, are you sure you're a woman?" And I'm like, "Yeah." And they'll say, "Oh, maybe you're a man wearing a woman's clothes." And the reason why they say that is because we come from a culture where men have accomplished a lot. I respect our men. I believe in families having both fathers, mothers, children, so that they can raise those children together. Refugee men are really, and there are a lot of men who are really hardworking, who are striving so hard. But what America has done for us is, because a lot of refugee women have access to women needs, the men have interpreted that. And it's true, the social service system is sort of tweaked. It supports women and children. And so, our men feel like the refugee woman has been empowered by the American system. And therefore, what that does is it implies that the families, the man and the woman, come apart. And so we see very high incidents around domestic abuse or divorce, which we wouldn't have had. Because in my culture, there is no place for divorce. I mean, if it's there, it's going to happen. But you've got the elder system that no matter what it takes, this family has to stay together. And who carries the burden? It's the woman, not him. And so but when we started working in 2001, and we started doing this work, it was hard. We were attacked, and I will tell my staff, I think our track record and the work that we do is what's going to save us later on. And so when I had this man, I'm just giving you a small story. This man came from Africa. He was in the area for a week, and he was told, he was trying to get phone services, telephone service. And, a lot of the African men will gather and talk about issues and what's happening in politics and all of that. And he will go to this gathering, at the stores, and he talked to 3 different men, and they tried to call the phone company for him. They were not successful. And then he was told, there are these women, a bunch of women, up on the whatever floor. They don't even call us by our agency's name. They call us a bunch of women. And he was told to come to us. And so he came around 4:30. We closed at 5. And I said, okay, how may I help you? And he said, well, I'm not sure if you're able to do this. He's starting with that. But I need some help. So I said, well, it's good that you came for help. I called Time Warner. I got him the service. I am not kidding. I got him the service. And then he sat back and he said, I just have to tell you this. And I said, what are you telling me? He said, when I was coming into this door, I never thought you were going to accomplish what I wanted. Like you wouldn't be able to deliver. And so I just came from Africa a week, in this city. I never trusted that a woman is able to accomplish what 3 men could not do. And so I'm going to go back. Well, I don't get offended, right? I can, punch him in his face and go to jail. But I didn't do that. And so he went back. And he told the other man, and he said, that man, when he sees me, he gets up every day. When he sees me, he's like, okay, I got to get up. I have to say hi to you while I'm standing, out of respect, because he never thought women. And so we come from that perspective. And so, we have to change that. And so we have to educate our men. We have to tell them, look, we are allies here. We're not enemies. We have to work together. And our community need both of us. And so it depends. It depends, but it's a catch-22 because, we come from a place where women are not necessarily considered very significant. And then here we are, outspoken, out there, telling them what to do. And how do you balance that? So, yeah. Sure.
We have another question.
Yesterday we were at Riverton, and one of the biggest questions they were asking was if we could help them with their knowledge of their medications and health once they're back in their community. And you're saying that your organization does this, and I'm wondering, is your organization local or is it statewide? And are there services like this available for all the different communities in Maine?
Yeah, Maine has very limited resources. It's hard, and we have so many different ethnic groups, all scattered in Androscoggin and Cumberland counties. We are probably the only refugee women-led agency in our state, and has been successful for 10 years. So we're 10 years old. Very excited about that. We became 10 years old August 2nd. Yeah. August 2nd of this year. So next fall, we're going to do this huge celebration for refugee women and girls. We have a small office in Riverton. We are out of Riverton now. And if there's a way, what we do is we go into homes a lot. And so if there's a way we can incorporate our outreach services into what you're trying to do, we are very happy to do that. We are based out of Lewiston, but we also have, we actually cover both counties. Although, when we started, we were responding to the influx of the Somalis in the Lewiston area. But we have now, since the video, have expanded to a lot of different ethnic groups. So we serve, one thing that I forgot to put in the slide was a puzzle that we always have that has all the languages and all the ethnic groups. So it'll give you a vision of, a visual of really who exists in Maine in terms of refugees and immigrants. So I'm happy to talk to you and see the way we can help in regards to that.
I know this was supposed to end at 1:30, so if you have to go, you should feel free to do so. But if you have more questions, we'd be happy to talk.
Thank you.
I had one more question, sorry. I know that you mentioned the asylum seeking. I know I have a couple friends in the area who are NPs who do health checks for asylum seeking people.
Yeah.
Do you know what sort of role other fields can have in that? I'm in the PA program here. Do you have much knowledge about asylum seeking and getting the health screening?
So our agency, in collaboration with a number of other agencies, medical care development, and a lot of us are really developing our refugee health plan for the state. And so tomorrow, we're meeting with Maine CDC and students from Hudson to help us do a scan around refugee health services in the entire state. Our agency works with a lot of asylum seekers. We're not like Catholic Charities, because Catholic Charities has to, I believe they have to have asylum granted in order for them to work with them, or at least have applied or something. We don't have no eligibility requirements around who can enter into our service. And so, and we have a very good partnership with many healthcare providers, many service providers who provide, a variety of services. And so if we get connected, I'm sure we can be able to help out with your friends. It looks like I'm done. I'm just kidding. No, no, I'm just kidding. No, go ahead.
I am an actual professional interpreter, so thank you for saying a good word for us. And I just have a question. Yes, we do have extensive training, but this term cultural broker, as an interpreter, it's only second time I only hear that. So where do I apply for it? It's not like you go to Maine Med, interpreters right there,
Right.
cultural brokers are here.
Right.
What,
Right.
what's the procedure for that, or how does it work?
I know. I said earlier, cultural broker is a fairly new concept in Maine. Cultural brokers are essentially people who have worked as interpreters but have worked in different systems. So, for instance, if so, there isn't necessarily a standard or a platform like the interpreters can sort of apply for this training and do this. There isn't something that's existing in Maine. We are at initial stages of really looking at the cultural broker concept, and is there some sort of formal training for cultural brokers that can be developed so that interpreters can go. So there isn't, the answer to your question is there isn't a place where you can go apply for. But cultural brokers are almost self-developed. It's a process. You develop yourself. So I can perfectly say I'm a cultural broker because I've done this work, for 10 years. So I understand the domestic violence system, and I understand the healthcare system, and I understand the criminal justice system. The cultural broker has to be specialized and have to have that added training. And one thing that we do when we go into, for instance, a doctor will request for an interpreter. And I'm going in as an interpreter because the cultural broker concept isn't necessarily there. And so I'm going to have to negotiate with that service provider and say, look, I know that you had requested us for interpreter services, and of course we have contracts in place with the service provider. They have all our accreditations and everything on file for them. But what I'm telling the service provider is there's going to be a place where we have hiccups. You are trying to provide a service, and this patient is going to need more education. And so I'm going to tell to a doctor and say, look, how about if I'll change my role. I'm going to negotiate with that doctor and say, or that service provider and say, I can't interpret anymore because I feel like I need to explain this. And so that takes me into the cultural broker role. And so I think there isn't really something that I can say, here's a cultural broker training and here's how you apply for it. It's a new concept. And it's hard to explain, but again, service providers may not necessarily be educated about cultural brokers themselves. And so you have to also, educate the service provider. So there isn't, but I'm thinking in the next year or two, you will really see more, because it's an added value. It's really an added value, much more than the interpreter. I really like interpreters. I respect interpreters. They do a lot of hard work. But the interpreter has a limited role, and the cultural broker has much more broader role. To me, I feel like we need that more than the interpreter, because the cultural broker can be the interpreter also. So I don't know if that answered your question. I'm sorry, but yeah.
All good? Thank you, and
Thank
thank
you.
you very much.